Hello guys, welcome back to my YouTube channel. From this video, I'm going to discuss about the anatomy of diaphragm. You will learn about the parts and relations, surface markings, attachments, apertures on the diaphragm, motor nerve supply, sensory nerve supply, as well as arterial supply and lymphatic drainage, and finally, what are the clinical correlations of the diaphragm. The diaphragm is a movable partition between thoracic and abdominal cavities. You all know this diaphragm separates the thoracic cavity from the abdominal cavity. It is a partly muscular, you can see it is a partly muscular and partly tendinous. Here there is a central tendon of the diaphragm. It is C-shaped, and periphery you have the muscular part of the diaphragm. It is the chief muscle of inspiration. The diaphragm descends during inspiration and ascends during expiration. You all know that it plays a major role in our inspiration and expiration. During quiet breathing, it descends for a distance of 1.5 centimeters, and the movements of the diaphragm can be observed in a living being by fluoroscopic examination. When we talk about the position of the diaphragm, it can be vary with the position of the body. If you are in the supine position, the diaphragm is highest and shows maximum movements, and if you are in the sitting position or the standing position, the diaphragm may be the lowest and you will not see maximum movements of the diaphragm. I told you previously as well, the peripheral part of the diaphragm is made by the muscular fibers, and the central part is the tendinous part or fibrous structure. The concave surface of the diaphragm or the inferior surface of the diaphragm forms the roof of the abdominal cavity, and it is covered with parietal peritoneum. Right side of this surface is related to right lobe of the liver, right kidney, as well as right suprarenal gland. And the left side of the diaphragm, the inferior surface of the diaphragm, is related to the left lobe of the liver, as well as fundus of the stomach, spleen, left kidney, and left suprarenal gland. The superior surface of the diaphragm or the central area of the central tendon is fused with the fibrous pericardium. Here you can see how the fibrous pericardium fuses with the diaphragm. When we talk about the surface markings, anteriorly the right dome reaches a point as far as the upper border of the fifth rib in the mid-clavicular line. Upper border of the fifth rib in the mid-clavicular line, like this. Actually, this right side, the right dome of the diaphragm reaches highest position due to the position of the liver. But in the left side, the left dome reaches as far as the lower border of the fifth rib. Here right side, it reaches up to upper border of the fifth rib, and here in the left side, it reaches up to lower border of the fifth rib. Posteriorly, right dome is the level with a point 1.25 centimeters below the inferior angle of the scapula, and the left dome is level with a point 2.5 centimeters below the inferior angle of the scapula. The central tendon is at the level of line joining the sternal joint to the spine of 8th thoracic vertebra. Let's see what are the attachments of the diaphragm. Diaphragm origin from three sides. They are from the sternum, from the costal area, that means lower 6 ribs, and from the vertebral part. The sternal part arises as two muscular strips from the back of the xiphoid process. Then the costal part arises as 6 muscular strips in the inner surface of the costal cartilages adjacent parts of lower 6 ribs. Then the vertebral part arises as right and left crura and by arcuate ligaments on each side. You can see these are the this is the right crus and this is the left crus. These are the arcuate ligaments here. This right crus is attached to the body in front of the bodies of upper 3, that means L1 to L3 lumbar vertebra and intervening intervertebral discs. Right crus is larger in size because due to the presence of heavy liver on the right side. Few fibers of right crus deviate to left of the midline and encircle the esophagus as here. There are few fibers of the right crus which encircles the esophagus. It goes somewhat towards the left side from the midline and encircle the lower end of the esophagus. And some fibers of the right crus are attached to duodenojejunal flexure as well. Here the left crus, this part is the left crus and it is in front of the L1 and L2 and intervening intervertebral discs. Then here the median arcuate ligament which joins right crus and left crus. It is across the lower border of the 12th thoracic vertebra. Lower border of the 12th thoracic vertebra. Then medial and lateral arcuate ligaments. Here is the medial arcuate ligament and here is the lateral arcuate ligament. Medial arcuate ligament, this part is thickening of fascia covering the psoas major muscle. Here there is psoas major muscle. So this is formed by the thickening of fascia covering the psoas major muscle, stretching from side of the body of first lumbar vertebra to the middle of front of the transverse process of the same vertebra. Then there is the lateral arcuate ligament. This lateral arcuate ligament is formed by thickening of the upper margin of the anterior layer of the thoracolumbar fascia in front of the quadratus lumborum muscle. Here there is a muscle called quadratus lumborum muscle. So this is the fascia thickened in front of the quadratus lumborum muscle. It stretches from the transverse process of first lumbar vertebra and to the 12th rib on each side. Here there is 12th rib. Here also 12th rib. Then what is the insertion of the muscle fibers? So the fibers of the muscular diaphragm here converge. Fibers of the muscular diaphragm converge towards the central tendon for the insertion. You can see those muscle fibers are converging. The central tendon has no bony attachment. You can see as well there is no bony attachment. It is somewhat C-shape and fuse with the fibrous pericardium superiorly. Let's see what are the apertures in the diaphragm. There are 3 major apertures in the diaphragm or major openings in the diaphragm. First one is opening for inferior vena cava. Here is the opening for inferior vena cava. It is located in the central tendon and at the level of T8, 8th thoracic vertebra. And here this opening is somewhat towards the right side from the midline. The wall of the inferior vena cava is fused with the margins of this opening. When the contraction of the diaphragm, it enlarges the vena caval opening, thereby dilating the inferior vena cava and increase the venous return to the heart. The branches of the right phrenic nerve pass through this opening along with the inferior vena cava. Then, second opening is esophageal hiatus. I told you previously as well, some fibers of the right crus of the diaphragm goes towards the left side from the midline and encircles the lower end of the esophagus, that is esophageal hiatus. It is at the level of T10 or 10 thoracic vertebra. So, when the contraction of the diaphragm occur, there is a sphincteric effect on the esophageal hiatus. That means we call it as pinch-cock effect. The vagal trunks and esophageal branches of the left gastric vessels pass through the hiatus along with the esophagus. You can see the vagal nerves here. Then finally you have the opening for thoracic aorta. It is at the level of T12 thoracic vertebra. And this opening is posterior to median arcuate ligament. And when the contraction of the diaphragm occurs, there is no effect on this opening. You can see the thoracic duct, and here you cannot see the thoracic duct, but remember that thoracic duct also goes through this opening, as well as azygous vein pass through this opening with the thoracic aorta. Other than these major openings, there are some minor apertures as well. Let's see what are they. Here you can see superior epigastric vessels. They pass through a gap between sternal origin and costal origin from the 7th costal cartilage. Here you can see T12 intercostal nerve or the subcostal nerve. So the subcostal nerves and vessels pass behind the lateral arcuate ligament. Here the sympathetic chain, you can see the sympathetic chain pass behind the medial arcuate ligament. I told you earlier as well, the median arcuate ligament forms over the fascia of the psoas major muscle. So this is the psoas major muscle. You can see very nicely, and this is the quadratus lumborum muscle. This fascia over the quadratus lumborum muscle thickened form lateral arcuate ligament. Greater and lesser splanchnic nerves pierce the crust of the corresponding side. Here you can see right side splanchnic nerves, and here you can see the left side splanchnic nerves. So they pierce the corresponding the crust of the corresponding side. And then hemiazygous vein pierce the left crust. Remember that here I'll show you here this hemiazygous vein pierces the left crust of the diaphragm, and here you can see left phrenic nerve piercing the central tendon. So that's all about the openings and the structures passing or piercing through the diaphragm. Let's see what is the nerve which gives motor supply to the diaphragm. Phrenic nerve is the nerve which supplies to the muscle of the diaphragm. They pierce the diaphragm. You can see right and left phrenic nerves piercing the diaphragm or the central tendon of the diaphragm. And right phrenic nerve supplies the right part of the diaphragm or right half of the diaphragm, while the left phrenic nerve supplies left half of the diaphragm. Let's see what are the nerves which give sensory supply to the diaphragm. Central part of the diaphragm and related pleura and peritoneum supplied by sensory fibers of the phrenic nerve. Irritation of the pleura or peritoneum of the central part of the diaphragm give rise to referred pain in front and tip of the shoulder, which is the area of cutaneous supply of supraclavicular nerves, that means C3 and C4. Here phrenic nerve, the nerve roots are C3, C4 and C5. So the supraclavicular nerves include C3 and C4. So there can be a referred pain or in front and at the tip of the shoulder. Then the peripheral part of the diaphragm is supplied by lower six intercostal nerves. When we talk about the blood supply to the diaphragm, superior phrenic arteries, which arises as the last branch of the thoracic aorta, gives arterial supply to the posterior part of the superior surface of the diaphragm. Then there are two terminal branches of internal thoracic artery as musculophrenic and pericardiophrenic arteries, and they supply anterior part of the superior surface of the diaphragm. Then inferior phrenic nerves, here starting from here, inferior phrenic nerves supply inferior surface of the diaphragm. Let's see what are the clinical correlations of the diaphragm. Here you can see this is a slide-in hernia and this is roll-in hernia. In the slide-in hernia, the cardio-esophageal junction and cardiac end of the stomach pass through the esophageal opening to enter into posterior mediastinum. You can see very clearly. This has gone upward. This is caused due to weakness of the diaphragmatic muscle surrounding the esophageal opening and increase intra-abdominal pressure due to any cause. There is regurgitation or reflux of acid contents into the stomach into this esophagus, causing peptic esophagitis. That means the main symptom of sliding hernia is heartburn sensation. And also the sliding hernia usually associated with short esophagus. This is roll-in hernia. Here, a part of the stomach passes through esophageal opening into the posterior mediastinum. There is no reflux of gastric contents into the esophagus as cardio-esophageal junction is in the normal position. But here you can see both cardio-esophageal junction and the stomach has gone upward. Here cardio-esophageal junction is in the normal position, only a part of the stomach has gone upwards towards the thoracic cavity. There is another clinical condition called diaphragmatic paralysis. There is unilateral diaphragmatic paralysis which is caused by damage to the one of the phrenic nerve. I told you earlier as well, motor supply to the diaphragm is given by phrenic nerve. So right and left phrenic nerves are there. So if one side of the phrenic nerve is damaged, the affected side, hemidiaphragm, can be paralyzed. So this condition can be diagnosed when an elevated hemidiaphragm, as seen on fluoroscopy, moves paradoxically. Usually, in the inspiration, diaphragm should contract and thoracic volume of the thoracic cavity should be increased. But here, due to paralysis of the diaphragm during inspiration, diaphragm does not move downward, it moves upward. So that movement is called as paradoxical movement. So in bilateral diaphragmatic paralysis, it is a nearly fatal condition which leads to respiratory failure because diaphragm is the major muscle which is responsible for our inspiration and expiration. Here you can see in this picture there is a herniated intestine in the thorax. That means usually in an X-ray we can see the air gas filled in the bowel in this area. But in this picture you can see the air-filled intestinal loops has gone towards the thorax. Here you can see very nicely this can be due to weakness of the muscle in the diaphragm in this area. So you can see in an X-ray of congenital diaphragmatic hernia like this. The intestinal loops are going to the thorax. Hope you understood clearly about the anatomy of the diaphragm. So if you like this video, please put a comment and put a like, and please share with your friends and subscribe into my channel for further videos. And thank you for watching.